Welcome to the Behavioral View.
We have to remain behavior analysts, but if we're going to integrate, then we have to be able to speak and understand the language that the rest of the world does.
We all have these conversations, and this is a step, reaching out to a pediatrician who is giving us some very good advice. And as we grow and move our own profession, there are lessons to be learned.
We are entering this, relatively speaking, uncharted territory. Like, we are definitely the new kids on the block. And we need to be listeners and watch and learn.
You can't just hand a chart to the parents to give to the psychiatrist. You need to send the psychiatrist a note at the earliest part of the treatment plan that says, "Hi, I'm a behavior analyst. These are the behaviors we're working on. Here's our approach to these behaviors, and I'll, be happy to send you a regular report on how we're doing. I hope we can work together to help this family."
Hey everyone, would you like to get a CEU for this episode? Listen closely for the announcement of 3 secret words delivered throughout the episode. Take note of those words, and we will tell you where to go to get your CEU when the show is over.
Welcome to the Behavioral View. I would like to introduce our special guest today, Dr. Steve Merahn. And Dr. Merahn, I could go on and talk a lot about your wonderful career. Dr. Merahn has graduated from the Albert Einstein College of Medicine. He completed his residency in pediatrics at a very famous place in the Bronx called Montefiore Medical Center. He has a long history where he started off his early career working with the New York City Department of Health. And during that time, he was instrumental in shaping policy, developing programs for early childhood, infant care, early intervention, and just a host of other very important problems that helped children with special needs. He also served as the chief medical officer for the U.S. Medical Management, which is a 14-state national primary care network. And most recently, he was the chief medical officer of Centria Autism. Dr. Merahn is a pediatrician, and he just has such a long history of working with parents, children, and their families, especially those with special needs. And he is a wonderful guest for us because we're going to be talking about behavior analysis and how that interfaces with pediatrics and medicine and healthcare.
Well, Steve, you're putting us all to shame here by that pedigree. And with that, I'm curious to see what is on that bookshelf of yours. It looks quite impressive. Given that we all are sitting in a room with a bookshelf, I'm going to challenge us all to grab one and let's see what we pick.
Okay.
All right.
Yeah, because the audience is going to be doing this. I've been seeing a lot of people looking on people's bookshelves in the background lately. So
that means all of us.
Let's go do it.
Grab one. All right, we're doing it.
Yeah.
Oh man. Okay.
I picked 2 because I want you to understand what my priorities are in life.
See, you are an overachiever.
I'm ready.
All right, Steve, being our guest, please go first.
All right, so I this is the one that I actually really wanted to pick, so I'm going to show you that first, and then my second one actually is important for today. But my first book, again, remember that background, but my first book is actually Corduroy.
Oh, I love that. I cry every time. I can't get through that.
I have 4 children, and none of them are preschool anymore. I mean, my youngest is reading Harry Potter. But this book is on my bookshelf and remains on my bookshelf along with a number of other children's books because, 2 reasons. Number one, this book is probably one of the first children's books that is really focused on diversity and inclusion.
Mhm.
There were not a lot of people of color in children's books, and so this is
Right.
important for us to all remember, but also because Corduroy is so relentlessly curious that it really just always reminds me to be relentlessly curious no matter what. And sometimes you have to look at the world around you, things that look like they make perfect sense, and interpret them in a new way, which is what happens to Corduroy when he shows up in the department store and discovers beds and always wanted to be in a bed and didn't really know what they were. And so that's really, this reflects me and my brain more than anything else. But for today's group, I would like to remind everybody of this book, which again, very important to me personally. It's a book called Teaching as a Subversive Activity by Neil Postman and Charles Weingartner. And it really is a book that reminds us about what is worth knowing and how we acquire knowledge and understand about the world in a way that's valuable to us. But it's not just about the things that we need to know, it's how to help other people understand the way the world works. So this was a book that was published in the early 70s, and this is actually one of the original copies. I've kept this with me all through medical school and training because there's so much more to this book than just an analysis of teaching methods, or as they say on the cover, outdated teaching methods. So that's my contribution to the bookshelf exercise today.
Oh, great. We'll have to add that to my list.
Yeah.
Shannon, you want to go?
Yeah. I mean, my fun books are in other rooms. This is the work room. So I'm sharing the first one that was on the top, the person-centered planning book.
Oh.
The stack that's right behind me is the non-ABA stack. So I actually come from the ID residential services world, and person-centered planning is the way of the world. And actually, I think it's going to tie in today here as we talk about interdisciplinary work. And love this book. Recommend. I think all behavior analysts should learn about person-centered planning if you haven't already.
For sure.
Rick,
Thank you. All right, Rick. What you got?
This is going to be a tough one, but hello.
Shameless plug.
A little bit of self-promotion there. What else could I show?
So that is Rick's new book that just came out just a few weeks ago.
Yes.
Mine I heard is in transit. I'm excited.
It is in transit. Yes, with a little nice note there.
Aw, thanks. Well, I would say that, I mean, you beat me to my punchline when I was like, I grabbed this one. But
we did not plan this.
And we did not plan that at all. But in real life, Susan Markle is an instructional designer. And this is Good Frames and Bad.
Yes.
And this is an old book. This is actually the second edition. And it's still old. It's falling apart. I got it off of eBay because you can't find this book anywhere. But it's a behavior analytic approach to instructional design, and this is just a gem. Like I swear, I'm not highlighting in it, but I want to. I want to be like one of those college kids who like highlights the entire paragraph because all of it I want to like soak in, and it's great when you are learning how to create instruction in a really a proper way, which I think sometimes we often miss the boat on in behavior analysis. So,
hey, wait, but before we go, this was my other choice.
Oh,
so I'm right there with you, Kerri.
Oh, look at that!
Round nosers.
Well,
I love it.
Yeah.
Birds of a feather.
Mm-hmm.
Amen.
All right. So, Steve, we invited you here because we all fell in love with your CR Unite presentation. And we want to talk more about some of those specific topics. But I got to say, the one thing that really, really stuck with me the most was when you pulled out a quote, and we'll show it to everyone, but meanwhile, I'll read it. And so this was in a response that you received when you inquired as to why ABA wasn't included in a review article of training recommendations for interdisciplinary work. And the reply was from the lead author, I understand that there are certificate programs and that there's a certification mechanism. ABA, in my mind, does not qualify as a discipline. For that reason, it was never considered for deliberations at our National Academy's workshop and related publications. And there were 13 authors, and they were psychiatrists and pediatricians and psychologists and social workers and case managers, but we were not there, and they didn't take us seriously as a discipline. So I kind of wanted to launch in. Maybe we can talk a little bit about, for people who may not think in these terms very often, a little bit about the difference between us as a profession and us as a healthcare discipline, but why it is that you think we're not taken seriously as a player, as a healthcare discipline from our peers and other disciplines.
Well, first of all, I want to preface this by saying that I'm not, this is not criticism. Okay, very important. I am extremely critical of my own profession. I am extremely critical of medicine as a profession. So when I talk about other disciplines, it's not to critique from the, I'm not on a soapbox with this, it's not a hierarchy. And that's one of the problems. One of the problems is that healthcare traditionally has been very hierarchical. The American Medical Association this year proudly promotes its campaign called Stop Scope Creep, in which they actively lobby at the state level to prevent non-physician professionals from expanding their scope of practice. That is an active commitment on the part of the American Medical Association. Now, the fact of the matter is, the American Medical Association really doesn't represent American physicians. The majority of physicians don't belong to the AMA. The AMA has a historical position in the ecosystem with power and authority associated with that. But the only reason I'm saying that, and I'm not attacking the AMA, I'm simply saying let's look at the facts of the way the ecosystem functions, which is physicians are at a hierarchical position of power in the ecosystem. So when that physician made that statement, he was doing it from what is a traditional position of authority over something over which he should have no authority. And so physicians traditionally have been the arbiters of what is quality care, and they are therefore positioned themselves appointed to arbitrate the relationships of other professions with patients. Now, psychologists have carved out their own space. Pharmacists have carved out their own space. Nurses have done an incredible job of coming out from under the subordinate role to physicians and carving out their own space. But in the course of doing that, in order to succeed based upon the way the system is organized, you end up creating these silos of professional identity. So the nurses have their own professional identity, the pharmacists have their own professional identity, physicians have their own professional identity. Behavior analysts have not done the work to carve out their professional identity in the healthcare ecosystem. And that requires work. And so, Rick mentioned something during my intro, which was so critical for me in terms of my development and the reason I can understand this. So when I joined the New York City Health Department as the medical director for the Bureau of Daycare, which is the licensing bureau for all childcare in New York City. 100,000 plus children back then. This was the 1980s. I have to admit, I'm a little old. So it was group daycare, infant daycare, family daycare, so home-based family daycare. We were responsible for licensing. And I'm a pediatrician. And I'm the only pediatrician among 24 master's trained early childhood educators, all of whom had significant experience running and leading early childhood programs. So I, as a physician, am now in the subordinate position because the dominant discipline for licensing childcare programs are childcare professionals, not doctors. So I had to find a place for myself. What's my role? I certainly could not, claim any kind of professional dominance, again, as this doctor did over ABA. It was not my place to do that. I had to find a role in which I was supportive, in which I was able to bring my expertise and understanding of child health and child development to people who were very expert already in child development and education. That has shaped the way I've worked in the world. So when I first joined Centria as the chief medical officer, I found myself in a very similar position. I'm the only pediatrician among, by the way, towards the end of my tenure there, 300 plus behavior analysts, including, a group of very experienced executive director level behavior analysts. And it was really my job to understand behavior analysis in order to bridge the shared care between the behavior analytic community and the pediatric community. And in exploring that, it was very clear to me that, again, for many reasons, the roots of behavior analysis in education, even the language, calling someone a learner versus a patient or client, because of the path that the profession has taken, the life cycle of the profession over the years, there really was not an opportunity to begin to carve out that identity in the healthcare ecosystem. Well known in the education ecosystem, not so well known in the healthcare ecosystem. But with the changes that began to occur as a result of the legislative reform state by state to support the use of ABA for children with autism spectrum disorder, all of a sudden you found yourself up against the boundary of the healthcare system, and in many ways not well prepared to manage the fact that you're actually really being absorbed into the healthcare ecosystem. Does that make any sense?
Yeah, it makes frustrating sense, but it does make sense. It kind of, one of the things that when you were talking, we asked the audience for questions ahead of time, or the potential audience for questions ahead of time. And we have one from Heather in California that kind of think relates into that a little bit. Mm-hmm. So do you think that part of the problem is that in some states, we're not even independent practitioners? So a lot of places, behavior analysts actually even have to work under supervision of a psychologist. Are those kinds of moves holding us back?
Well, that the reason you may be working under a psychologist in certain states may have to do with the power of the psychology lobby in that particular state, similar to the AMA looking for their Stop Scope Creep program. And their pride, this particular time, their pride was in the capacity to prevent physical therapists from doing something independently without an order. I think that some of that is holding you back, but it also has to do with during the time that the regulations were being written and brought into and brought forward, you didn't have the authority to advocate for yourselves. And again, I see this all the time. I'm so grateful that the ABA community has allowed me to participate in things like some of the Facebook groups for ABA business. But I see people in shock at this idea of medical necessity. In shock, what does this mean? And the fact that let's tell you something, physicians are just as in shock. So you have to realize now you are part of a much bigger community, and you need to look up over the wall you've built around yourselves, and we'll get to that in a second, because to some extent behavior analysis has built a wall around itself. And some of that's self-protective, we understand, but it's time to break down. You got to build some gateways, because if you have behavior analysts who are shocked at insurance companies doing medical necessity, there's a 40-year history of medical necessity. And there's a body of literature, and there's all sorts of experts out there who have been dealing with this issue. Why aren't you part of that world? So,
and Steve, I think going back to what you were saying earlier, this beautiful description of what you described about you working with early childhood is talking about playing nicely in the sandbox. And I think that that's something that we have struggled with historically. We struggled with, like you said, that you would learn the terminology and you went out and you essentially you described like you would listen, you took the back seat as opposed to being like, I'm the authority. You will listen to me. I have the credentials. And you're like, yeah, man, you know your space. I'm going to sit back and I'm going to listen to you and you're going to school me. And, oh, that's the language you're going to use. Okay, I'll use that language. And, and you're right. Like, we are entering this, relatively speaking, uncharted territory. Like, we are definitely the new kids on the block, and we need to be listeners and watch and learn. And even in this licensure space, Shannon, that you're talking about, like, we don't know how to lobby, like, I mean, parents who, parents were the ones who were successful at that, not behavior analysts. If it was up to the behavior analysts, like, we tried and we were unsuccessful. And, with the uniting of parents, that got done, but it was like, there's so much, like, there's in so many licensure bills, there's an exclusion of having teachers also be required of having licensure. Yeah, because teachers have been doing this for so long and they're like, we're not getting on that. And right. And they have this powerhouse of knowing how to lobby, right? So they are so effective of not having them be included in our licensure bills. So if we want to be on this, learn this skill set, I think that we need to take a page out of Steve's book and know how to participate in a newish to us, right, community, and be listeners and be learners, and not having to wave our egos around.
Yeah, I mean, again, I'm without being critical. Remember, I belong to a professional society, the American Academy of Pediatrics, and I know that my professional society's mission is to protect our discipline. We are advocates for children, and that comes first. But second is, we want to make sure pediatricians are treated with respect and bring are able to make our contribution without interference.
Sure.
I think that your professional associations, largely, with the exception, I think, of ABPA personally, but I think in many ways the BCBA, your certification board, has created a firewall that does not really support the collaborative relationships. I've presented twice at ABAI, and I, it's very academic, and it's not particularly interested in the place of behavior analysts in the world. It's about behavior analysts. Now, by the way, this is true in pediatrics as well. Last year, for the first time ever, a presentation on ABA was made at the American Academy of Pediatrics meetings, but it was made by a pediatrician. And that's true. In general, these are not interdisciplinary meetings. They're meetings for the discipline, and therefore they tend to be, disciplinary silos. But at the same time, you look at the committee's functions in the American Academy of Pediatrics, whether it's, the Committee on Neonatal Care or Psychosocial or Child Development, and there's all sorts of collaborative work going on. There's a deep relationship between the American Academy of Pediatrics and the National Association for Education of Young Children, for example. But there's no similar relationship between a behavior analytic group, which in this case, the obvious one would be ABPA, as representing the profession, not the discipline, but the profession. So you want to talk about the professionals, not the academic discipline. But where are those relationships? And some of it will be resistance on the part of the pediatricians, because that's what happens. But at the same time, there has to be a commitment to being part of the broader community. And I find in general that because of this issue of disciplinary silos, whether it be, an article on children that's published in the in a psychiatry journal, if it's not a child psychiatry journal, generally doesn't make it to the pediatric community because there's not a lot of this bridging between these two groups. And if you all want to be not just accepted, because it's not up to them to accept you, you have to create your space in the ecosystem. Mm-hmm. And so it's not like someone gives you permission to go there. It's you just say, okay, we share the care of children right now. The vast majority of behavior analysis in the United States takes place with children with autism spectrum disorder. And so the fact of the matter is this is a shared care relationship. Okay, all the other people sharing the care of these children, how can we ensure that we integrate and orchestrate these therapeutic relationships? And I will say at the same time, just personally, some of the vocabulary may need to change. I'm just going to say this. I want my child to mand, said no parent ever. Ever. So, you've got to think about that. How do you fit? And this, by the way, is a cultural issue. How does the culture of your profession fit into the broader ecosystem? And if you want to have a place to increase the diversity of the ecosystem, the professional diversity of the ecosystem, then you have to find your place in that habitat, to use some ecological examples.
Yeah.
And again, some of this has to do with the way behavior analysts are trained. And some of it, by the way, is an artifact of what's happened over the last 10 years as the economic drivers of ABA as a career have changed. Mm-hmm. And I think that's had a profound effect on the profession, particularly as you have more and more people who are coming into it because it's a good job now. It's not just a passion for the discipline. It's, this is a place that's growing. There's a need for talent. I always kind of liked kids, so sure, I'll do that. But that's a very different cohort over the last, and I was intimately involved in the onboarding process of new behavior analysts into our network. And the level of variation in the commitment to the profession and the concept of being a professional as opposed to being a technician, in many ways we're moving or have seen the movement of behavior analysis from a diverse professional discipline to much more of a technical discipline. And I think that's actually doing your profession a disservice.
Well, that kind of leads us to another question that we have. We have these tiered levels that, like you said, technicians. So, right, we have the RBT, which serves as a technician. They provide that direct care. We have BCABA, which really there's not a lot of cohesion around. Some they just supervise, some are delivering that direct care, some it's a hybrid, right? You have your BCABA or BCBA, and then there's the BCBA or BCBA-D, which is there a difference? Sometimes there's not a difference in function, and right. So how would you compare these in the healthcare field? Like, is there a model that we could say like, oh, well, the RBT is kind of like this in this healthcare model, or should we strive for there to be one like this? Like, I wonder, when I took my kids, we go to the university family center for my kids for their healthcare, because I like that I'm going to maybe get this wrong, the residents or the attendee. I never know where the residents and attendees are on the hierarchy. Yep. I need to brush up on my Grey's Anatomy. But they're always up to date on the latest research. And so, they come in and we have the consult and it's great and everything. And then comes in the overseeing attendee. And so then they give the rundown from the resident. The resident gives a quick summary. The attendee says, hey, do you have any questions for me? How was your time here? And I'm like, great, lovely day. This person was awesome. And, we go on about our day. Like, is this a model that we are looking at for these tiers, or is there another model that you see, or?
Well, first of all, I would advise you not to follow someone else's model. I think as a profession, you need to find the model that works for you. So let's just talk about medicine for a minute. So what happens is you graduate from medical school, and you need 1 full year of training after graduation to become licensed. So you graduate from medical school, you don't get your license for a year with additional training. That training is called an internship or residency, depending. It used to be that you could do 1 year and be done, hang up your shingle as a general practitioner or community and do fine. These days, almost everybody does a residency of one kind or another. And residency is usually anywhere from 3 to 7 years, depending on what you're doing. Mm-hmm. Neurosurgeon, 7 years. Pediatrician, 3 years. General surgery, 5 years. So it depends on what you're working on. When you are an intern or a resident in the hospital, you are working under supervision. Mm-hmm. You can write orders. Mm-hmm. You can make diagnoses, but you're under the supervision of what you call an attending physician. That's the medical side. But there's other professions who also can provide very high levels of care. Nurse practitioners in many states are licensed to order tests and order drugs. Again, to some extent, depending on the state, under supervision or not, sometimes you can operate independently, but your notes needs to be signed off. And then there's physician assistants. We used to call both those groups, PAs and nurse practitioners, we would call them a horrible name, physician extenders, again, because of the dominant hierarchy of medicine. I think the physician assistants, if you look at their website, they have carved out their own independent identity, mm-hmm. even though there are some legal regulatory obligations for accountability. Mm-hmm. But to tell you the truth, right now, if I was having cardiovascular surgery, I'd rather have a good PA put me on the heart pump than one of the physicians put me on the heart pump.
Interesting.
So they've carved out their space very well. So you might go to the doctor's office or a clinic and see a nurse practitioner, or a PA, or one of the physicians in training, or the attending. I think when I talk about the technician aspect, though, I'm actually talking about BCBAs. Mm. So, I mean, yes, in RBT, there's, again, because of the talent needs of the community right now, the fact that there are so many children who are on waiting lists and waiting to be served, and we need to train. So there's this kind of path that we've put many RBTs on. We ask them at some point, you want to advance your career? Yeah. Okay. 2-year online master's program. And then we'll get you your whatever, 15 or 1800. I don't know what it is right now. I know it went up to 1800 hours of practicum, and then you can sit for the exam and you can go to work. But the fact of the matter is, I think that training puts people into the field before they're prepared to be clinicians. They may be technically trained to do a technical care plan. And when I say that, it's a matter of, okay, I'm going to see this child. I'm going to do a VB map. I'm going to look at where the gaps are in the VB map. I'm going to create a care plan in which the next level of the VB map is the goal. Mm-hmm. And as long as my care plan focuses on that next level of VB map, I know I'm tracking them upward.
Yeah. But then, what if you have a kid that doesn't fit a standard assessment that you have on your shelf ready to go?
Well, then you go to social media and you ask what you should do.
Right. Well, so at the same time, though, you've got a whole host of things that go along with being a professional in the healthcare system. Shannon, person-centered care becomes the base of this. How do you, can you look at the whole child? And the whole child, by the way, might mean, as you said before, Kerri, recognizing that other disciplines have other views of children that are not necessarily reflecting the principles of behavior analysis. Mm-hmm. And so I actually have 3 years of training in psychoanalytic psychotherapy for children. Mm-hmm. And I don't consider myself a psychoanalyst, but I was interested in behavioral health, and this was an opportunity to get trained. So I'm not beholden to that discipline, but I know a lot about it.
Right.
And I see where many of the principles of psychoanalytic thought are very valuable to me as a pediatrician. I'm here, and I hope this reflects my profound belief in the power of behavior analysis. This book, by the way, edited by my friend and colleague Henry Rohn at Upstate Medical Center, describes, a dozen additional indications for ABA beyond autism. And so, when we're talking about the growth of the profession, we have to look at the growth of the profession not from the perspective of how many children with autism can we take care of, but how can we ensure that we have well-rounded behavior analysts who can serve and sit at the table with other clinicians and hold their own in terms of ensuring that the power of this discipline is reflected in our intervention design for children. That it's not one or the other. It's not behavior analysis and rejecting, psychotherapy, because, by the way, some children need both if we're really going to reflect the whole child. And that's what I'm saying. In many ways, the profession of behavior analysis has drawn this, has built this wall of protection to a certain extent. But at the same time, you're kind of talking to each other now, and you're not allowing, again, this kind of biodiversity of the ecosystem that you are increasingly a part of.
That is when you spoke at CR Unite, I asked you a question, and it was about, I said something like, what do you see behavior analysts most comparable to? And you mentioned nursing. And that sent me down this path where I started exploring how did the nurses actually carve out their niche. And, they have this book called the Nursing Outcomes Classification. I think they're like in their 6th edition, but it's this book that says, look, as nurses, here are all these specific things that we must adhere to. Here's a standard way of doing it. And in our own field, those are things that we need to do. We need to start embracing standards, because while we're a discipline, we have many non-standard ways of doing things. As a matter of fact, I would say many of, like, how do we view graphs? They're all non-standard. How do we collect measures? They differ from person to person, even though they come from a similar place, and people could select different measures. So I guess I'm thinking, through your experience, you did mention we shouldn't ape another group. We should come up with our own kinds of our own model regulations and so forth. But if we wanted to reach out and we wanted to be more multidisciplinary and start forming connections with other people, how do you see that playing out?
Well, first of all, what's the locus of control over that? In pediatrics, there's the American Academy of Pediatrics that represents pediatricians. And then there's the American Board of Pediatrics, the certifying body. And those two bodies are nonprofit organizations that are purely focused on setting standards for the profession. And if you want a statement on, the developmental consequences of digital health tools in infants, the American Academy of Pediatrics is the source of that information. There is no other organization, and other people might try, but that's the locus of control. Right now in behavior analysis, you've got 4, and they're all competing with each other, by the way. So you've got the BACB. It's 5. You got the BACB. You have ABPA. You've got CASP, which is all of a sudden taken on things that the BACB was doing in terms of regulatory work and is now putting out standards and practices. And you've got the BHCOE, which is an independent organization. It's a business. And by the way, there's nothing wrong with that. In medicine, we have the National Center of Quality Assurance, NCQA, sets standards across the entire industry. But for your discipline, there's no one knows where to go. Who actually represents the organization? Who actually represents the profession? And so, part of it is you all got to figure that out, because you're a little fragmented. It becomes very hard for people to know where to go when things are that fragmented. And, I think, again, given the fact that, to me, the ABPA is really equivalent to the American Academy of Pediatrics in that you're representing not academic research of pediatrics. By the way, there is an annual meeting for academic research in pediatrics. It's different from the AAP meeting. The AAP meeting has to do with the profession, the actual pediatricians themselves. But then at the same time, the certification body, where are those standards coming from? I see that a little fragmented right now. You talked about the nurses declaring themselves in terms of what their contribution to care is in terms of outcomes. There are no outcome measures for ABA. Certainly, there's no specific outcome measures for autism. I'm telling you right now, the payers are going to ask for it more and more. They're going to want to see what is the benefit, what is the value. That's the big word right now. What is the value of what you're doing? And value is not just we help the child. Sadly, that's not what value is in today's largely healthcare economic model. But the fact is, you've got such a foundation to do it from. It's remarkable. So, and again, Rick, you and I have talked about this. The measurement piece. I have to say, there's a group of behavior analysts that have been taking the Johns Hopkins COVID data and plotting it on standard acceleration charts. And as a former public health physician, I spent 7 years in public health. That is singularly one of the most accurate, comparable approaches to tracking, and the medical community knows nothing about it. We continue to do traditional, non-comparable graphic representations of the rate of change in medicine. So I look at it.
I was going to say, we can't criticize.
Yeah, the behavior analytics community barely knows it, and those that do are kind of like, eh.
Well, but I want to say, to me, when you said you were looking at nursing, I think number one, getting nurses and psychologists and teachers and physicians, and when I say physicians, because it includes adults as well, adult medicine as well, family physicians and internists, to get them to understand the potential contribution of behavior analysis as a science to their work is critically important. And that to me is the first gap. The second gap is to get those communities to bring behavior analysis into their toolbox. So it's not just a matter of having a behavior analyst on the team. That's one form of collaboration. But the other form of collaboration is to have medicine, the broad capital M medicine, look at behavior analysis in the same way we look at genetics and immunology and biochemistry as a basic science. So the immunologists go do stuff at a basic science level, and then the clinicians come along and say, oh, that research finding is transferable to the clinic. And that's a place where I think behavior analysis can make a massive contribution. In the last week, there have been 2 articles published in the medical literature on how teams provide better care than individual clinicians. 2 articles published about how teams provide better care than individual clinicians. And I'm like, you had to study this? Like there isn't a body of literature see this phone? This phone was not developed by a person. It was developed by a team. It was developed by an interdisciplinary team. And the group of people who put this together did not, like the user interface designer didn't come from a department of user interface design and reported to a chairman of university interface design. So there are huge bodies of knowledge out in the world that if we just focused a little bit on knowledge transfer, we could really affect tremendous change. And I think, and again, I'm going to hold up Henry's book because, you open to the first chapter, you're open to the table of contents here, and we're talking about neurology and dentistry and ENT and feeding disorders and acquired brain disabilities and ADHD and sleep and obesity and all these kinds of problems that the child health community struggles with every day. There's a contribution that is possible from the behavior analytic community. And I don't know whether it's the only one, but I will tell you, you all have to accept the fact that if you offer these, you're going to have to prove it to them. You can't just say, believe us, because that discipline has a methodology that in which things are benchmarked. Now, having said that, one more talk about methodology. One of the things that I've read over the years about the ABA research is that it's not a randomized controlled clinical trial. And the fact is, the behavior analysts argue, and again, Rick, Kerri, all of you, correct me if I'm wrong here, argue, well, we're doing, it's basically an N of one study. We're going to go in, we do an intervention, we do a reversal, we withdraw, there's actually a legitimate discipline to that research. And the fact of the matter is, with increasing acceptance of personalized medicine based on genomics in healthcare, this idea of N of one studies is increasingly getting accepted. But has the behavior analytic community ever presented its research methodology to these other communities like nursing? And because there's problems that nurses have all the time that are behavior based. And so you have behavioral health problems, autism, ADHD, OCD, anxiety, etc. And then you have all these health related behaviors, like medication compliance. I always wondered why doesn't every ABA provider in the country, when you go to assess a child with ASD under one of the existing programs, does your child have any other comorbidities, any other medical problems, asthma, epilepsy, very common? Why isn't medication compliance instantly part of the treatment plan to ensure adherence to treatment plans? Yeah. That contribution alone could allow behavior analysis to say, oh, by the way, we're really good at kicking people out of the emergency room.
Yep.
That puts you in the value chain.
Yep. And
that's the kind of thinking that increasingly will give you again, that's how you carve out your place in the ecosystem. It's not, oh, please give us a space, let us sit down with you. It's watch out, we're here because we actually know what we're doing.
We really like preaching to our own choir.
I mean,
well, again, in shameless plug mode, I am actually working with Dr. Gina Green at ABPA on a conference in June called Bridges to Behavioral Health, which brings some of the top talent, including some people we know very well, from. And by the way, what I discovered is there's a boatload of really experienced behavior analysts, PhD, BACBs, who are on the faculty of medical schools all over the country. And that, it just dawned on me, that would be a very interesting group to bring together, behavior analysts who actually work in departments of pediatrics, because they would have a very unique view of their role and place in the ecosystem today. But I bet you they could be organized to kind of move this forward because of their, where they sit, if we armed them with the right messaging.
The first secret word is value.
You covered a lot in the last couple of minutes, a lot of different topics. And I don't know, I keep coming back to your message about, basically you're saying we've got to be bilingual. We have to remain behavior analysts. But if we're going to integrate, then we have to be able to speak and understand the language that the rest of the world does, right? The rest of the medical world does. So not understanding groups design research, for one thing, and not being able to kind of flex into talking. I don't know. I have a double feeling about this, and you guys can help me work through it, I guess. On the one hand, we have to be able to understand psychiatric diagnosis, medical diagnosis. On the other hand, I worry so much about young behavior analysts who already are so heavily influenced in just the cultural model of pathology and mentalism. And we work so hard in their training to get them to think behaviorally, behavior, not broad categories. I preach constantly, we are not autism doctors. That's not what we're doing here. And so there's definitely a training piece missing, right? Where we have to be able to talk, we have to be able to collaborate, we have to speak the language of the other folks, but we have to preserve what it is that we're actually bringing to the table.
Yeah, no, and that's why, by the way, I said before, don't try to mimic the other professions. You need to find the roadmap for a behavior analyst based upon your needs. And I think part of this is to be able to, you can sit in a room and find your contribution while people are talking about more inner life type issues. You have to respect them. That's their contribution to that whole child, that person-centered care, and then you make your behavioral contribution to the person-centered care. It's part of it in the training part, though, as you're saying, is the training for the certification exam is very technical, and there's not a lot about professionalism and what it means to be a professional in an ecosystem that's part of that training. So I think a lot of this has to do with how people are being trained right now, because they're being trained based on a very technical model. And there are ways to expose people in training to the challenges of being a clinician in the world. And that includes 1 second, Kerri, that includes both your responsibility to your patient/client as a clinician, in terms of interviewing and relationship management. And, I have learned so much from acceptance and commitment therapy as a pediatrician about how and the power of acceptance and commitment to long-term goal setting and adherence to treatment plans. I've absorbed that completely. I use the phrase acceptance and commitment all the time. Most of my fellow physicians don't know where it comes from, but as I explain what that means, they're like, oh, yes, affinity and loyalty become critically important. The sense of commitment to the plan. So, and I've kind of adapted that to my own needs, but the fact is that's not even a part of the training of a behavior analyst. So there's that part in terms of relationship with clients. Then there's, again, the relationship with others. What is the nature of the shared care model? And I'm not the person to talk about this. Pat Freeman's been writing about this for almost 20 years. There actually is a body of literature in the behavior analytic literature about this idea of kind of shared collaborative relationships with other professions. So you just got to go to your own discipline. It's there.
Yeah, we struggle on what our training should be. This is a big ongoing talk in the behavior analysis community. I guess the question is, where do you put it and when do you put it? What do you take out? 7 years on top of your medical training is a lot. And I'm thinking that neurosurgeons probably have an ultimate payoff that's a little bit higher than what your average behavior analyst gets. So I don't know where it goes is the problem. Kerri, have you solved that problem yet?
No. I was just highlighting that, I think that it seems as if the way that it's set up, the professionalism piece is, I think it's like a wish and hope, where it's like, I really hope that you're getting this at your practicum placement.
Mm-hmm.
Since the practicum piece is required, it's like, I really hope that you find a good one. And I really hope, right? And then I really hope that you're getting this the soft skills training on how to be a good professional there. And it's not tested, it's not evaluated, and if you don't get 1 and 2, then right, because it's not checked. And I think that that's where, going back to kind of like a common theme that we've been having in this conversation is where we come up with some BCBAs, and like, like you said, you're critical. Like, I think it's okay for us to be critical of our own field in a healthy way, because we want it to get better. But it's just saying, like, we have a reputation of not playing well with others, where the BCBA shows up to the IEP meeting and everyone's like, ugh, all right, what lecture are we getting now? So it's, here's the know-it-all. and yeah, you know, maybe that person, you know, maybe they do, maybe they don't, but it's also about our delivery. So that's where the soft skills piece comes in. It's like, so at your practicum, did you get training on how to provide suggestions on how that IEP could be a little bit stronger without making everyone else in the room feel like an idiot? Or how to be collaborative with the teachers and with the SLP and with the OT, you know, how to make them understand your point without, you know, waving your credentials in their face, you know.
And by the way, if you're focused on behavior, you should be observing the behavior of the people you're speaking to, because you can read the room
Exactly.
without knowing what's going on up here. You can see people's reactions to you and adjust your verbal behavior accordingly.
When I was, you know, in a practicum placement, it was like you go in there like a bulldog, and, you know, but when I actually took a training from an IEP advocate, she taught me how to massage the room. She taught me, like, okay, so now you get their buy-in, and when you start talking, you nod your head, and you're like, well, doesn't Tommy do this? And when you nod your head, and everyone's like, she's like, it's so hard not to nod your head in agreement, right? Oh yes, Tommy does do that. You know what I mean? Like these little tips. I mean, it's, you know, like it's so funny how, you know, and, you know, she has no credentials. She doesn't, it's not about ABA or OT or with her. Like she's not, you know, this IEP advocate was not adhered to one thing or another. She had a child with a physical disability and learned how to fight for services for her child.
Well, it's honestly, it's goal achievement.
Yeah.
You're trying to, you know, manage behavior towards goal achievement, and it's the same kind of behavior analysis.
Well, if we ever get to vote on it, I will vote for. I do think that needs to be in the curriculum in school. I mean, I'm not going to go into my history, but came through to behavior analysis in a very weird way, and my training is actually in educational psychology and counseling psychology, and that's the first course before you do any practical stuff. You really literally just sit in a room with someone with a bunch of people watching you through glass, and you're not allowed to do anything except make that person feel heard and accepted for what they are saying. And I think we could really benefit. I mean, it's a 1 semester class. It doesn't take a lot of time.
Yeah, one of the tools, again, from outside behavior analysis, but it turns out that there's a connection, is something as practical as motivational interviewing. Which actually does have its roots. I you know, when I proposed this to some of the behavior analysts I was working with, they initially go, no, that's not from us. But the fact of the matter is, there's a nice body of literature that shows the relationship between motivational interviewing and behavior analysis. But that kind of work needs to be done. People need to say, okay, what's going on outside that actually is based upon our professional, our discipline, what is based on our science. We may not have created it, but it's based on our science. We can validate that, and we can bring that in, because I think there is a lot based on your science that could be brought into both your profession as well as others. You know, Kerri, you said something before. Both Shannon and Kerri said something before, which triggered a thought in my mind. You've got RBTs, BCABAs, BCBAs, and BCBA-Ds. I would say that there's probably value in the world for the equivalent of what we call in medicine a fellowship. So you can, when I finished my pediatric training, many of my colleagues went on to a specialty fellowship. It's not a degree program, but it is a specialized training program. So you can do a fellowship in developmental behavior pediatrics, you can do a fellowship in neonatology, you can do a fellowship in hematology, oncology, but you go for that kind of narrow specialty view. But I wonder if there's an equivalent in behavior analysis of a fellowship. Again, not a PhD, but, you know, a 2-year commitment. And it would be interesting to see if some of the behavior analysts that are working in departments of pediatrics would be willing to, again, support this idea of a behavior analytic fellowship in the health environment. I'll give you an example. A good friend of mine went to dental school and then did a 1-year general dentistry fellowship at Bellevue Hospital in New York City. So it was all about experiencing dentistry from that more intensive care perspective. It wasn't around. It wasn't about periodonture or it wasn't a dental specialty. It was really about spending an extra year to get some intensive experience in this particular unique environment. And I wonder whether there might be some value, because I bet you there are of those BCBAs who come up through what is currently the ranks, young, early career, didn't come at it from an academic perspective, never thought about getting a PhD, never wanted to teach, never wanted to do research. They just want to be a clinician, to kind of evolve a subgroup of them who get this more intensive experience in collaborative environments, with supervision from some of the behavior analysts that are already there. And that would be a very, very valuable training ground for people who don't necessarily want to commit to the academic path of the BCBA-D.
I think it's a cool
It'd
idea.
be highly valuable.
Yeah.
And
Well,
that takes away some of the pressure from trying to squeeze all of these classes in to a 2-year master's degree program, because we definitely do have an access issue.
Right. And by the way, these are paid jobs. They're not
right. Yeah, they're not working for free.
You're not going to get the kind of money you're going to get from a private equity funded ABA program these days.
Sure.
But the fact of the matter is, if people really want to become clinical supervisors, or they want to go on to leadership roles in the profession on the clinical side of things, that would be a great milestone. Again, not a BCBA-D, but to have finished a fellowship would give you, and actually would give all the ABA providers at least a sense that this person's made a commitment above and beyond, 3, 5, 7 years of experience. And we are seeing more and more people getting their, investing the 2 years, investing the year-ish, getting their certification, and then like the next day they want to be clinical supervisors.
Mm-hmm. Oh yeah. Yeah. No, I remember when I was working at, we have a small practice in Reno, and I would interview people. I'm like, oh, you graduated 2 years ago. And they're like, yeah, and I'm like, where do you see yourself? Oh, I really would like to be the clinical director. I'm like, okay. Yeah. It's just like and I love that they have that ambition, and that ambition's needed, but it's so early with so little experience. In addition, like, I sure didn't get my master's degree in 2 years. Like, back when I went to school, we walked in the snow barefoot 12 miles, but like it was, a lot of these courses, when I applied, there was very little PhD programs, and granted, I got my master's along the way, but we did a thesis where that's not times, that's not an option with many of these master's programs, but also with that, because I was still gathering data, I was taking additional courses and learning, and then that means additional time at my practicum placements. And we had a requirement, like we did a stipend and a practicum placement to make sure that we got a whole bunch of experience. And so by the time I actually got my master's degree, it was, had been in school for 4 years, been in graduate school for 4 years, and had tons of experience that when I sat down and took the BCBA exam, I was like, well, actually in this question, not necessarily, because this question needs more information. Now, granted, the test has been revised and it's much more polished now, but it was, you knew too much for the exam at that point, where everything was conditional, and you had to be like, take this exam as if you just read, the Cooper, Heron, and Heward book, right? So it's a different setup now.
And
again,
some of that's,
go ahead.
Some of that's shaped by the environment, and to some extent, the profession may have to wrest some control of that.
For sure. And I think that if we don't have this like additional year of fellowship, and if, you're not okay with a 5-year master program, then it's like, then you need to take the ownership upon yourself to find these opportunities of saying like, this isn't the end of my journey. This is the start of my journey.
Yeah, that I have to say, that to me was one of the most difficult things when I was doing onboarding. And again, I didn't actually do the onboarding. I'm not a behavior analyst, but I was the executive in charge of the onboarding process. That there was, to me, as a physician, my first responsibility is to lifelong learning. Most people would say their first responsibility is to their patients, but if I don't do lifelong learning, I will not be able to be responsible to my patients. And I did not see that as regularly as a shared value among people who tended to see passing the exam as the end point of a process that they're done. And so to me, that's something that really needs to be focused on if the profession wants to really find its place, which is the commitment to lifelong learning. And it's not just lifelong learning in the field; it's lifelong learning as a clinician,
right.
As a person who is a helping person in the world. There's a lot of things you need to constantly be absorbing from around you, filtering, prioritizing, choosing to go deep in some or in others. And I'll give you an example from my own career. I was in the library decades ago, and I sat down at a table, and on the table was a copy of a journal called the Journal of Verbal Learning and Verbal Behavior. And it had a yellow cover, I remember distinctly, and I sat there with my books and was ready to study, but this thing was sitting there, and I picked it up and looked at the table of contents. And on the table of contents were some really interesting articles about how people thought and how they communicated. And I'm like, wow, I'm a medical student. This probably is relevant to the stuff I'm learning. And that honestly became a thread in my career. I started to really look at both the literature on communication and the literature on cognitive science. Even though I didn't have a class in cognitive science and I didn't have a class in verbal learning and verbal behavior, but because I was in the library and this journal was there, and to this day, and by the way, that became the basis of a 10-year detour of my career at one point into the communications business. But, it's really served me in terms of my work particularly, by the way, as I became more of an administrator and executive leader, as I learned more about, again, verbal learning and verbal behavior. I didn't know it was behavior analysis at the time. It was just this amazing set of literature, people who were studying how people absorb words and how people hear things verbally. It was just, wow, there's a connection between this and medicine, even though, by the way, that was considered a basic science. That was not part of the curriculum at all. So, that's a thread that is, again, and I know you all are committed to that between the Institute and Dave's work. But that's a place where there might be some capacity for you to support the community in a certain way.
Well, let's do it now because we have some lifelong learners who sent in some questions, right?
Okay, let's go.
The second secret word
Rick, do you have
is
them pulled up
training.
already?
Yeah, I do. So we have a few questions. One is from Bailey in Mississippi. And Bailey asks, is it common for other states to have lobbyists for their state organizations to help push for better rates and for the right to be independent practitioners? Is this an effective way for us to grow?
Absolutely, yes. I can tell you, I was living in New York. I was on sabbatical for last year, and there's a woman who essentially lives and works in Albany who represents the New York State chapter of the American Academy of Pediatrics, who tracks legislation and sees elected officials and reports back to the chapter on a regular basis about that work. The teachers have it. Interestingly enough, in New York, the New York Behavior Analytics Society is super active. It's actually one of the few that really does have a very active lobbying program. But I think that, again, the idea of the connection between, what's the locus of control for this? Are the local chapters, what organization do they represent when they're out there? And how do people know that it's representing their needs? What's the agenda? Is there a national agenda set that each state then implements? And then are there local state agendas based upon what's going on at the state level? So coordination of that becomes critically important. But yes, if you're not present, you're absent, and other people will step in, as happened with the National Academy of Sciences meeting, and say, "Oh, I don't think you guys are really a profession. We're just going to marginalize you."
Mm-hmm. I think that's a really good point for our viewers to capture that last sentence that you just said. Yeah. If you're not doing something, someone else is going to step in and make a decision that you're not going to be happy about. One thing, because I've been active in the legislative process here in Nevada, I was on our state licensure board, and I have testified for increasing Medicaid reimbursement rates because ours is the lowest in the country, and actually we lose money at the RBT rate. It's hard because, BCBAs historically, are like, pulling the 40-hour week, that's actually a 60-hour week, if you're looking at drive time and billable hours only, like the terrible setup system. So you have that, but then we're asking, take time out to volunteer for your state chapter, because, that's not a paid position, or take time out to testify, because our last legislative session, we had about 4 bills that were related to ABA or autism. And so if it's hard, because then okay, well then that's taking away from my salary, right? Or my time to manage my team, or hours that's given to my client, right? And so but if they don't do it, then we, what's rushed in is that there was, lobbyists on the other hand, or Medicaid didn't want to increase rates, and right. So there's other people that are making decisions for you, and it's incredibly hard. And then you have your state chapter who, there's 3 people volunteering for that, and all of the weight is on their shoulders. And then they are the ones who have to be in charge of recruiting money if you want to have a lobbyist take all of this over. It's just this terrible, vicious cycle, but it's worth it in the long run, right? We need to step up. We need to take on this responsibility, because if we don't, someone else will.
It's a professional parity issue. The teachers do it. The physicians do it.
Yep.
So, and by the way, same problems,
teachers have a class.
But I'm a member of the Michigan chapter of the American Academy of Pediatrics. I'm back in Michigan, and there's many members, and then there's a subgroup that regularly volunteers for committees and things. But I think the idea of, we need to support each other and make sure that our voice is heard is a little bit, again, and a lot of it has to do with professional identity. To some extent, I'm not sure all the behavior analysts that are being minted today really understand their responsibility to the professional community.
I don't think that some understand the difference between certification and licensure either.
That's possible too. But I'm just talking about, you take that exam and you get this credential, and there's a community level obligation that goes with that credential. It's not just yours to go make money with or get a job.
You do right by your profession.
You have right, exactly.
Yeah.
And if you don't, if you don't, respect the profession and the history of the profession and contribute to the future of the profession, that credential loses value.
Yeah.
And
it's a really good
You know
point.
what? This is heaping guilt upon me, because I will point out I am in Mississippi. I do know Bailey in Mississippi, and yes, you're right, Kerri. There are about 3 or 4 people doing all the work on the state level. Bailey is one of those.
They need some help, Shannon.
No. Can we
Well,
get some
and I
carve
think
out of
that
my time?
and I think it's also, and this is my plea to, some ABA agencies out there is that, and for the few that, at least in Nevada, I know that it was important that advocacy and licensure and stuff like that was important to them, and so they found the outlet to allow a representative from their practice to do this work, especially during the heightened level of open session, right? So I think, so my call is on the agencies of the state, is saying, like, even if you're a small practice, like, gives, if someone feels compelled, or encourage someone, say, like, hey, you got a big voice and you're not afraid to use it, will you help your state chapter, with the legislative process? Will you help them, especially if, I think I just saw that there's some activity in North Carolina where they're trying to get out from under the psychologists. So, I think that's a great movement. So if there's a way that, an agency can find value in that without having the BCBA be penalized from giving,
or for the state chapter to take perhaps a different view of their relationship with the agencies and set up an agency council and say, look, there's membership dues for agencies, and the dues will go towards this type work that is mutually beneficial to both the professionals and the agencies, because we're all, again, it's this ecosystem concept.
Yeah.
Well, and not only that, but some states are much further along with all of this than others. So being in one of those very small and mighty states where we don't even have 100 behavior analysts right now, I don't think. So we really don't have experts in how to fight for ourselves. So if bigger states, further along states would mentor the states who are coming up through the pipeline, I think that would help as well.
Well, I think there's actually a monthly meeting with I don't know if it's explicitly about licensure, but there's a monthly meeting about state chapters that they get together.
I think we got to move past licensure too. Once you're licensed, and then it's just a matter of, can we get paid now, please? Yeah.
So naive question though. There are state organizations. Do they roll up to a national platform?
Well, they're chapters of ABAI, and then they are they can be like, it's called I think it's called accredited by APBA, but it's just an association. So APBA, APBA wants to just be like, you get a gold star by saying that you're with APBA, but they don't want to like be heavily, and
I understand. Yeah. Okay.
Let's move on to some other questions.
Sure.
Let's see here. We have Leanne in Arkansas. We got a couple people from southern states here.
Somebody from the south might have been reaching around.
Stepping up here. Leanne says, I give reports with graphs of the target behaviors to families I work with that they can then take to their child's psychiatrist. I'm always amazed at how often the psychiatrists, come out of those appointments the families with orders that are completely contrary to what the data indicated. I do know that sometimes the parents want med increases, even if they are not effective, because the hope of a quick resolve is preferable to the huge amount of effort involved in following behavior plans. But sometimes it seems like the psychiatrist just does not value the data. What can I do as an independent practitioner running a small business to develop a more collaborative relationship with medical doctors serving the same clients?
Well, first of all, the way you present the information may not be absorbable by someone who's coming at things from a medical model. So you're asking them to think in ways that they may not have a conceptual framework to understand. So some of it may simply be in the presentation. And what are you asking them? What are you asking them to do? And you need to be explicit, because they're not going to make the leap
We're back to bilingualism again.
To what you want them to do. And so you need to explain. And again, does the chart have the word "manned" on it? Because if it does, there's the word.
That's true.
Right.
So what is it? The nature of the report, the information architecture of the report is critically important, because I'll tell you the way our physician brains are organized. Number one, I need to know the basic science of what you're telling me. Once I understand the basic science, then I can understand how things go wrong, the pathology. And then once I understand how things go wrong, I can understand the signs and symptoms associated with that pathology. And then once I understand that, I can begin to pick my therapy. Mm-hmm. So if you're looking to balance the medical model against your behavior analytic intervention, you need to show very clearly how those two things relate to one another. It's not either or, because you will not be able to say to a child psychiatrist, you can stop giving the medication because I'm doing this instead. That's not going to work, because they're coming at it from a different perspective. But you could say to them, I've created this graph that I'm going to ask parents to use to track the behavior that you're trying to eliminate with your medications. So let's see whether we can actually track the behavior with the meds, and then we're going to do this other intervention on the side, and again, explain how that works. Because if they don't understand the basic science, they're not going to. And by the way, very hard to say, I'm not going to learn your model now. So again, it's this: what's the information architecture of the report? What's the ask? What are you asking them to do or think? And then how can you demonstrate the nature of the mutual relationship so you can each bring something to that child, instead of it being, stop doing what you're doing and we're going to replace it with what I do, even though I'm a psychiatrist. I will say it's interesting to me that it's a psychiatrist. I would think it would be more of a pediatrician, but if you're talking about kids on meds, then it's, most of those are written by pediatricians. Aren't necessarily always comfortable writing some of the more sophisticated or complex medications. They may do ADHD meds. They may do some anxiety meds, but it's unlikely they're going to do some of the meds that are associated with severe behavior.
A nod to what you said earlier about establishing good multidisciplinary relationships. There are people, behavior analysts, for example. I know one school in Pennsylvania that happens to use charts. They chart the medication changes on there. They give it to the psychiatrist, and that's a wonderfully informative relationship, because now the psychiatrist is looking at the child's data on these standard charts and saying, oh, okay, why don't we try this adjustment? And that only happens when you are including the medical professional, explaining what you're doing, and having them be part of what you are doing.
Yes, and so here's a great example of that. Parents may go to their psychiatrist and say, I really want my child to stop tantruming. And the psychiatrist says, okay, great. You know what? We're going to do an observation. We're going to check this out, and we're going to try a particular drug that I know can often reduce the incidence of severe behavior. Behavior analysts can actually ask the question, can we narrow down exactly what we mean by tantrum in this child? Because a tantrum in child A and a tantrum in child B actually may manifest themselves in terms of very different behaviors. So let's get a little more precise about what we mean by tantrum. And now, psychiatrist, I'm going to, help support your therapy by giving this tool that says, is your medication actually changing the tantrum-related behavior that is specific to this child? And then at the same time, by the way, I've discovered that there are certain motivating operations for these tantrums in my work with children. And I'm going to work in parallel to this medication to try to see if we can modify those motivating operations and provide some reinforcement for the child to express this behavior less frequently. Now the psychiatrist is going, okay.
Yeah, and they do, because, intermediate care facilities, it was mandated. All psychiatric treatment had to be interdisciplinary, and the behaviorists had to provide graphs, not only of the target behaviors, but also of side effects, because so many of the population weren't able to communicate those. It made a huge difference when everyone was sitting around the table every single appointment. So it wasn't just people reading each other's reports. It was talking about and explaining what I meant by that.
But if you know, like Kerri was saying before, if you show up at the IEP or you show up at the psychiatrist's office,
Yeah.
you know, you're not going to get much here.
Right.
I think it's
But
also,
you're wrong.
Yeah, exactly. Right.
Right.
Well,
Anyone.
and even in that same vein, I think it's important here, and that I'm kind of picking out from this question, that the parents wanted an increase in medication. And so if that the psychiatrist is going along with the parents' wants, now granted, I'm sure, the psychiatrists and pediatricians aren't being like, oh, just because you want it, I'm going to give you an increase in meds. But like, I think, if it also is in alignment with, a practice, if the psychiatrist is like, would you want more behavior therapy? Like, do you want to stick that, or do you want more meds? And the parents say more meds, then the psychiatrist is going to honor the wishes of the family. So I think that that's something that is important, that like, even if the behavior analyst is like, but it's working, we're doing good, and the family's just like, I want more meds, like, we honor the wishes of the family.
Well, along those lines too, the fact that the parent is asking for more meds there's a secondary communication there to the psychiatrist that says this other thing isn't working.
Right. Like,
and
go ahead.
No, and so the behavior analyst is like, no, we're doing great. No, you're not, because the parent's telling you you're not.
Exactly.
So,
it's like the data could be great, but it could be exhausting. There could be competing contingencies at home, that like, mom's like, listen, I am busting my butt, but like, I have 2 other kids and I'm trying to manage this, and I really can't see myself doing this for another month. Like, it was so hard to do this right now, and I just don't have it in me to continue it anymore. Give me the pills, right? Like, there's so much that we don't know in this scenario. And I think that, you're right. Like, it's a preference assessment.
Right, exactly. Well, the other side of it is just going back to this question. Let's wrap it and go move on to it. But if you're a new behavior analyst taking care of a child for the first time, one of the things that you really need to do is communicate with all the other members of the child's care team very early in your relationship with the family. So you can't just hand a chart to the parents to give to the psychiatrist. You need to send the psychiatrist a note at the earliest part of the treatment plan that says, hi, I'm a behavior analyst. These are the behaviors we're working on. Here's our approach to these behaviors, and I'll be happy to send you a regular report on how we're doing. I hope we can work together to help this family. That goes a long way to getting the next report understood, because they may not understand the context at all. But I think you're right, Kerri. I think there's so many other things going on. It's back to Shannon's point about person-centered care. You're not just treating the child, you're really treating the whole family.
Yeah.
So we have time for one more question. And this will be one that, since you had experience at Centria, I think you might be able to speak to this. And this is from Anonymous. Anonymous says, I notice a lot of divide between BCBAs working for different companies, and this seems to be holding us back. In my area, physicians are more willing to refer to us once they know who we are and what we do. However, we do not have the capacity to meet all the need. Despite that, organizations are unwilling to refer to one another. I think this lack of respect for one another is preventing the rest of the healthcare community from taking us seriously. Is this a problem across the country?
I do think so. I think that when again in medicine, you tend to set your practice up or go to work for an organization, and you commit to the community and you stay, and you're known. You're known in the professional community. It helps with referrals. It helps with backup. It helps with coverage. It gives you a network to rely upon as a professional. I do think a lot of the movement from organization to organization does undermine some of that sense of stability. Some of that is also the the ABA provider companies have some obligation to develop a relationship with those communities as well, to let them know that they are stable, that they are committed to the community. But I think to some extent the level of familiarity and comfort with the particular, it's less about the BCBA specifically, unless they're running the business, and really more at the organization level at the organization level. The other thing that I think is conflicting to some extent is the balance between nonprofit and profit organizations right now. A lot of the nonprofits are anchored in the community. A lot of the organizations may be new, and it's up to those new organizations to establish their credentials. Did that get to the question? I think I skipped something there.
The question, to me, I'm a little confused because the first part seems to be asking about one clinician working for multiple companies. And then the second part seems to be like what you were addressing, Steve, when it's talking about referrals.
No, I'm reading it now. I think it's just BCBA's working in different organizations, not one in multiple, but
okay.
Organizations
between BCBA's working for different companies. Okay. Yeah. Okay, good. Because I was like, I definitely have thoughts about that. But okay, but if it's just about the referral process, then I think it's selfish not to refer, because like there is not an organization out there that doesn't have a waiting list, and
right.
There.
Yeah. Okay. That was the part I missed. Thank you.
Go for it.
I have to say, and this doesn't always happen in healthcare either. You can have two hospitals, you got 3 hospitals in the same community, and they're not necessarily referring to each other, except, by the way, in emergencies where they do emergency department diversion or their ICUs are filled, but then they do it. And I think given the fact that, if someone's got a short waiting list and someone's got a long waiting list, I think there's an ethical obligation to ensure people get to care as quickly as possible.
For sure. And I think it's also, for us, we would always refer to be like, these people we know, like if you're calling us, hopefully you heard about our reputation, which we take, we have a lot of pride in. We also, if you can't get service from us, then go here. But then on the other side is that, there's also places that don't have the same level of quality of care. And yes. I don't necessarily agree that some service is better than no. Like there's some places that, I've seen that then finally the family comes back, they're like, oh my gosh, we were just there. And then now this kid has problem behaviors through the roof because of some inappropriate treatment plans. And so it's, I would say like, no, yeah, I wouldn't go there because of lack of supervision. They never saw the BCBA. So it was, I'm not going to refer there. And it's not for a lack of division because the business and I want all the money or anything like that. It's nothing to do with that. It's about protecting the client and the quality of care. So yes, there's definitely, we have a referral list that we send whenever someone is on our wait list, and we say, here's a referral list, call these places as well, get on their wait list. And then there's certain people on that list, and others are excluded.
All right. Well, we're getting towards the end of our time, so I think it would be fun to wrap up with just the wish list. If you could make one thing happen right now, what would you make happen?
If you were the king of the world.
There you go.
What I make happen right now. If I could make one thing happen, it would be to bring the science of behavior analysis as a basic science into the healthcare system.
The third secret word is science.
Well, we have learned so much from you, and can't thank you enough for spending your time with us, for giving us this deep insight. we all have these conversations, and this is a step, reaching out to a pediatrician who is giving us some very good advice. And as we grow and move our own profession, there are lessons to be learned. I think what's important is, the medical profession, in one way or another, has been being practiced for a long time. When you compare that with psychology, psychology hasn't been around as long. And when you say, carve out behavior analysis, which is even, a shorter period of time, there's a lot of growing we have. And of course, the profession's always changing. In healthcare, now that we're being part of that, is changing. So this has been very helpful for us. So on behalf of my colleagues, Kerri and Shannon, I'd like to thank you for being our guest on the Behavioral View.
Thank you. Thanks for putting up with my rants today.
We enjoy your rants.
We love them. Yep.
Talk to you soon.
Thanks so much. Thanks for watching this episode of the Behavioral View. To get your CEU, follow the link and instructions below the video. You can re-watch the video there, or you can go straight to the attendance verification quiz, where you will enter the secret words and pay the CEU fee to generate your certificate. You have already done the work, you may as well get the credit.